Okay, hi. Can you hear me? Can you hear me? Just check, please, if everything is fine. Let me set up my AV now. I hope everything is okay. Just check, please. Hi, everyone. Just check your audio. Just check your video. If everything is fine, if the system is fine, and if you can see me and hear me very well. Good morning. Good morning. Hi. Hi. Good morning. How are all of you doing? All of you are good? Good morning, bache. Good morning. If everything okay, just check your audio now. All fine. No echo, nothing. Is everything okay? Just check your audio settings right now. I've removed my video. Just check your audio setting first. Is my sound visible, audible to you without any disturbance? All good, Aditya. Very good. Okay, okay. Chalo, nice, nice, nice. Okay. So let's begin, bache. Let's begin with what we want to do. Let's begin with what we want to do. Okay. Now, is the audio okay? No, the audio setting I think might be also a problem at your end. Just check. I'm not sure though. Just check if everything is okay. Audio? No audio? Akshay, no audio? Okay, just check please. Everyone, can you please confirm? Can you please confirm? KD audio is okay? Yes. Okay, so bache, some people who are facing some issues might be at your end. Seems to be okay from here. Okay, cool, cool. Right. So chalo. Namaste. Namaste. Hi, how are you? Okay. Good morning. Good morning. Uh, it's let's start with a sentence that I always believe to be true. When we actually talk about dermatology, when we talk about dermatology, what the first thing that's very important for you to know about, the first thing that's very important for you to know about is the fact that dermatology is a subject which I'm sure none of us have too much idea about. Is that not correct? We don't know too much about this subject, which seems to be a subject which is kind of those neglected orphan subjects. I call them orphan subjects कि जिसपे कोई ध्यान नहीं देता है ना. तो तो होता यह है कि उसके माँ बाप नहीं होते डर्मेटोलॉजी के ना, तो मतलब वो बच्चा यूं ही घूमता फिरता रहता है. पुअर फेलो, nobody takes care of it. So in medicine and surgery and OBGYN and PSM, all of us have some idea in MBBS, but how many of us know too much about dermatology in the undergraduate course? I can tell you about me, not much, right? The only thing I remember knowing, because I used to be very scared about my, posting ending exam, and my teacher used to ask me, what have you read in dermatology? And almost 99% of our batch used to say scabies. And my teacher once asked कि क्यों ऐसा क्यों है कि सब लोग scabies ही क्यों बोल रहे हैं. And then she realized scabies was the first chapter of the book that we had. So that means we only could reach till the till the first chapter, right? So this is just for me to tell you that it's okay if you don't know anything about dermatology right now, or know some little bit here and there, and not know too much. So let's begin with the assumption that we are zero right now. Let's begin with an assumption that we are zero right now, and we bring you up to where I want you to be for the entrance exam. So it's a jump from there to there, right? We're expecting about 10 questions to come in dermatology. We're expecting about on an average about 8 to 10 questions about dermatology. That's a good portion. That's a good number of MCQs. And this will take for me between anything between 20 and 22 hours to cross that journey, okay, from not knowing too much to knowing the entrance exam portion, right? Everybody okay? Yes, tell me, give me a thumbs up on whether the everything is fine, your settings are fine. Are you able to hear what I just said? Are you able to hear what I just said, please? Huh? Okay, right. Chal. Now, how will I reach this portion, right? How will I reach this portion? Let me give you a perspective. First, don't have to write anything. I'm just going to give you a perspective. First is it's going to be about 20 to 22 hours of dermatology, right? That's one thing I want you to do. Now, in this portion of dermatology, I'll have two or three things. One is I'm going to show you videos. These are animated videos. Now, I'm just going to play one video. Just see if you can see this video, please. Just see if you can see this video. Okay. Just check. Okay. So, can you see this animated video, please? This animated video is something that I will actually play for you, right? So that I'll explain whenever I come to it, what is the actual portion. That's the first thing I will do. I'll give you a nice video kind of a part also. We'll do a lot of concept building, obviously, right? Otherwise, what's the point of teaching if I can't tell you concept? Okay. I will also love, and I do this a lot, I'm going to show you and rather tell you a lot of analogies. Analogies matlab real life situations which compare to dermatology. Analogies means real life situations which compare to dermatology. And these real life situations will be very easy to correlate with your dermatology, right? Now, what happens is this is obviously a very big portion, not a small portion, and we want to finish it in time. Okay. Now, there are going to be some slides, okay, which are, I feel, very heavy to write down. Okay. I think they take a lot of time to write down. Okay. So, these slides, what I have done is I will give this slide some number. Okay. I'll have a number on that slide. So slide 1, slide 2, slide 3, slide 4. I'll show you the example of these numbered slides, please. Okay, look at this numbered slide. Can you see I've given it a slide number? Slide 1. Now, I think this takes more time than usual. So you have two options. You have two options for these numbered slides. Okay, I will not wait, by the way, for you to finish writing this big slide. Okay, I'll explain it obviously, but I will not wait. What I will do is you have two options. Either you don't write down and leave a gap in your book. Leave a gap in your book. Okay, so it's going to be slide 1 gap, slide 2 gap, slide 3 gap, slide 4 gap. Okay, so gaps like that. Now fill this gap up later on. I'm going to show you in this particular Telegram group. I'm going to send you very soon a PDF of all these numbered slides. So what this does, it helps me save precious time, and we can use that time obviously to do more portions. So that's the first thing I want to tell you, the slide. These are slides which are going to be numbered, which are going to be given to you. Clear? Okay. Now I will also have images obviously. Now the problem with images is you're going to forget images, right? So what we'll do is we will also have a PDF of images that again I will be sharing with you. Okay, I'll be sharing two things then, the PDF of the numbered slides and the PDF of the images. Image PDF will be shared after the entire class is over. Image PDF will be shared after the entire class is over. The numbered slide PDF will be shared sooner. The numbered slide PDF will be shared much sooner. Do you understand this, please? Okay. Now this is what we want to do. And I am excited to tell you something. And students actually, when they attend my class, students as they attend my class will usually always find that there is one more thing that I find is nice for me to talk about. I'm a big fan of this. Okay, and you'll be surprised as to why we're talking about this. You'll soon realize that as the class goes ahead, we'll try to link so many diseases around food and nutrition. Now, this is something which I feel is often ignored, okay, in your MBBS course and even in your MD course, even in your DM course. Not many people will know the exact science of nutrition and food. So, what happens in India is we are actually becoming sicker and sicker and sicker. Why are we getting so much diabetes and hypertension and fatty livers and heart disease and everything? Okay, yes. In fact, yesterday I read a very shocking article which is published by one of the leading hospitals that now it seems that India has become the cancer capital of the world. And there has to be some reason for that. We are going to actually explore a lot of things about nutrition. For example, I'll explain whether the yellow of the egg can be taken or no. Yes, cool, please. Whether fats are good for health, what can you have, what carbohydrates are good, whether juice is good, whether Coca-Cola is good. We're going to speak so much about it. So for the first time after the lecture is over, you will have some idea of the things that we decide every day, whether to have dosa or whether to have masala dosa. Yeah, yeah. So we will have actually a lot of data which tells you these very essential daily living decisions that all of us often take wrongly because we have no idea about nutrition and food. We'll also speak so much about so many myths, right? For example, we'll speak about which is the best soap to use for having a bath. What is the best sunscreen? How do you choose a sunscreen? Whether coconut oil is good to use on your hair, which shampoo to use, and these are very daily life decisions which impacts your life. And I'm sure, as a faculty, I think I should be able to tell you that also, rather than only discuss the psoriasis pathogenesis. We'll also talk about which is the best soap to use. So this will really help you understand so much beyond dermatology, right? So all my blessings to you. Okay, all my good wishes to you, and I hope you have as much fun as I will have in taking your class. Thank you so much for being here and sparing your time, which is often, obviously, I can understand your time. This time is precious, and you're trying to prepare for something which is a major life event for you, which is an entrance exam, right? Okay, now we start by, okay, we start by putting in a link. Okay, now this is the link for my Telegram group, and I would want you to join that, bache. Okay, you can scan this, please. You can scan this, please. You can scan this, please. Or what I can also do is, give me a moment. I'm sharing the QR code in your group also. 1 second. I'm sharing it in your group also. Okay, I've done that, please. Okay. This will be important for you to join, because a lot of what I will do will also be on my Dharma group, right? Okay, so you can join it, please. Okay, I've also shared it on your Telegram right now. Done? Chalo. Let's begin. All okay? All geared up? Give me a thumbs up. All good? Okay. Chalo. Chalo. Let's first do, write down, bache, anatomy of skin. First, let's go to anatomy of skin. First, let's go to anatomy of skin. Anatomy of skin. Okay. Now, all your questions, bache, okay? All your MCQs and question which you want to ask, any doubt, please go ahead and put it on the DBMCI regular post intern Telegram group. Don't put it on my group. Okay, the MCQs which you want to ask. Any doubt, please stay on the DBMCI regular post intern group. Okay, okay. Anatomy of skin, please. 3 layers of skin. Okay, 3 layers of skin. The topmost layer लिखिए is the epidermis. Below that is the dermis, and below that is the fat. Please copy epidermis, dermis, fat. Three layers of skin: epidermis, dermis, fat. Fat is also called as panniculus. क्या बोलते हैं बच्चे? Fat is also called as panniculus. Now this line in between epidermis and dermis क्या बोलते हैं उसको? Dermoepidermal junction. क्या बोलते हैं? Dermoepidermal junction is the line in between the epidermis and the dermis. Okay, the line in between the epidermis is called DJ. Now can you see the DJ is an up and down line? Now why is it an up and down line and not a straight line? Let's understand that. Why is it an up and down line and not a straight line? Let's understand that. Listen very carefully. Why is it an up and down line and not a straight line? Now let's say I take my index finger and I push my own skin. See this, I'm pushing my own skin. If I push my own skin, can you see the epidermis, dermis moves together as a unit? You don't find epidermis moving on the dermis, right? Dermis doesn't move on the fat, they move together. That's how it should be. Imagine if that was not happening and I do this and only the epidermis moved and the dermis did not move. That'll be strange. If I do this, imagine, if in my offline class somebody is sitting in the first bench and I do this and the epidermis flies off into that girl's lap. She's like, "Chee, sir, what are you doing?" I said, "No, I don't know. Sorry, I just did this. My epidermis came off." Okay, you went to school and put a bag on your shoulder. Imagine the epidermis stripping off with that strap, right? We didn't do that. We didn't have that, right? Because epidermis did not move independently of the dermis. They moved together. Now, for it to move together, it's not nice to have a flat line between epidermis dermis because the epidermis can easily slide over. Okay, that you don't want, right? So what do? Keep the dermis like this with fingers going up and epidermis like this with fingers going down, and the upper fingers go into the gaps of the lower fingers. Can you see now? There is no chance of movement. Excellent. So that's why everything moves together, and that's why we have some stuff going up. These upward projections from the dermis, which I just showed, this one which goes up is called the dermal papilla, and what goes down is called the reteridge. So please label dermal papilla, and this is the reteridge. This is the reteridge. Okay, everybody okay? Okay, now I'll be more than happy for you to express whatever you feel. Okay, I'm someone who allows a lot of expression, which means that I'll be very more than happy if you can share emojis and whatever GIFs. I have no problem. Okay, whenever you want to share something, please go ahead. Okay, you have a free thing from me. Now you like something, you feel like laughing, you feel like crying, whatever you want to do, right? You want to take your tongue out with your emoji, I'm okay with that. Put that up. So that is it. That's how we make an online course lively. See, I don't have any of you to see. I'm in a room, right? I'm looking at four walls. How do I feel your presence in my mind? How do you feel my presence in your life is going to be able to have some kind of feelings and emotions, and we are very happy with that. Okay, so let's not be very serious. Let's be very cool about it. Let's chill up. I'm going to make a lot of jokes. Let's be very cool and very chilled out and very let's not have too much stress, at least about dermatology. I'm going to make it very lively, and it's going to be a nice simple enough class for you. कोई टेंशन नहीं आएगी. बीच में कभी आपको लगा कि पूछने का, सर मेरे को एक एंटी डैंड्रफ शैम्पू बता दो, हो गया, नाइस इनफ, राइट? सो कूल. सो ओके, डॉक्टर डिटरमाइंड. Okay, you are determined. Okay, right. In fact, now that you say determined, I have one disease named after you. When we talk about leprosy, there is something called as indetermined Hansen's, right? So I think you can change your name to indetermined. Don't say Dr. Determined, say I'm indetermined. मेरे को पता ही नहीं life में क्या करना है. That's what the real thing about life is. No, you can't understand what you want to do in life, right? Okay, right. So this is now understanding the dermal papilla concept, right? Okay. Now epidermis typically has three layers. Epidermis typically has three layers. Okay, epidermis has typically three layers. ठीक है? Now what are those three layers? Sorry, not three layers. Sorry, four layers. Sorry, four layers. Okay. Okay, what are those four layers? Let's draw those four layers, please. Okay, the top layer is called stratum corneum. Okay, the top layer is called stratum corneum. Okay, the word corneum means keratin. The word corneum means keratin. Okay, the word stratum means layer. So it's a corneum layer, right? Stratum corneum. Why do you have keratin? Keratin basically is for strength. Keratin is basically for strength. You need strength. Okay, you need strength. Understand? Why do you need strength? So you see, can you see you're holding a pen? Where is the trauma of the pen going? The trauma of the pen is usually going to the stratum corneum. So maximum trauma comes to the stratum corneum. Yes, no? Yes, maximum trauma goes to the stratum corneum. So stratum corneum has to have the maximum keratin. For example, let's assume it has 1000 milligrams of keratin. As an example, I'm saying, not real example, real thing, just an example. Now, stratum granulosum is a layer below. Now, the reason it's called granulosum is because this layer seems to have a lot of granules. Okay, now this granule has been called as keratohyaline granule. Okay, this granule is called keratohyaline granule. Okay, now this SG layer is very thick in the disease called as lichen planus. Write down please, lichen planus, and it seems to be absent. We'll talk about this later on in the disease psoriasis. Okay, in the disease psoriasis, it seems to be absent, this layer, and in lichen planus seems to be thickened. Okay, now do you realize it is not going to have as much keratin because it's a bit deeper. So क्या होगा, the body will say, अरे यार, I don't need so much of keratin because the pen trauma is not coming so much. So this will let's have 100 milligrams of keratin. So can you see the keratin has reduced now, right? Corneum has the maximum, then you reduce that. Then below that you have a layer which is called stratum spinosum, SS. The word spinosum means these layers have spine-like projections. Spine-like projections called as desmosomes on their surface. Called as desmosomes. Okay, so I'm going to draw this for you, please. Can you see this? Can you see the desmosomal? Can you see this desmosomal edge? A spinous edge, है ना? Now, do you realize this will have even less keratin? Maybe 10 milligrams of keratin now. Can you see the reducing keratin at every step because it's more protected and the pen trauma doesn't come there, right? Okay. Below that is the stratum basale and below that is the dermoepidermal junction. A stratum basale seems to have vertical cells. Okay. These are dividing cells. Now, can you see this will have the least keratin? So maybe 1 milligram of keratin. Why? Because obviously the trauma is that much lesser. So can you understand one thing please? That as you go down in the epidermis, there is lesser and lesser need for keratin, or on the other hand, we can say that as you go up, you have more and more keratin synthesis, and this has been called as keratinization. Do you understand please, bache? Keratinization of the epidermis. Keratinization is basically an ability to make more keratin as you go up. Tell me if you understood that. Everybody be with me. Everybody correspond with me. Everybody talk to me. Everybody say okay if you understood it. I need to see and feel a human presence. Understood? Clear? Okay. Now this keratinization is important. From bottom it goes to the stratum corneum. Bottom, say stratum corneum is what happens, right? Okay. Now see now. We know that stratum corneum, stratum basale here and stratum corneum on top. And then from here it falls off. Clear please? So below to up and it falls. This fall is usually invisible. Have you ever seen that fall? Imagine, right? This usually takes about 28 days. Okay, this falling, when it starts from the bottom, it takes about 28 days. So can you now say that I can say that it takes 28 days for the cell to shed off, about a month? So I can say that my skin renews itself Every 1 month we have new cells forming and it falls off, but I don't see it. Imagine if I were to see it, how strange would that be? Imagine if once a month my skin sheds from head to toe. I get up in the morning, and that happens in a snake, by the way. A snake can wriggle out of its old skin. Snake can wriggle out of its old skin, and the old skin is behind and the new skin is is what it gets. Do you That's called molting in a snake. Do you mold like that? Tell me. Tell me that. Do you molt once a month? Do you get up in the morning and say, "Mummy, or it's going to be a tough day today. I'm going to come out of my own skin." Tell that person, "I'm going to be late today." Okay, you are going to be late to office, and your boss asks you, "Why were you late?" Said, "No, sir, I was coming out." Coming out of what? Of my own skin. Oh, I understand. This is that time of your month where you're going to shed. Okay, please take care. I will grant you an official leave of 2 days every 1 month. It's going to be sanctioned by the Supreme Court that those days will be tough for that person. Don't come. Are you getting that? No. No, you've only made an excuse that my dadi is lost her life for the 10th time, right? Or I was stuck in traffic. Imagine saying I was stuck in my own skin, right? But that's not happening because it's an invisible fall. What if it's a visible fall? If it's a visible fall, it's called a scale. If it's a visible fall, it's called a scale. Okay. Okay. Let's show you a scale then. Let's show you a scale first. Okay. Let me just show you a scale. Can you see, bache, what a scale looks like? Okay. This is what a scale is. A scale is just a visible falling of your skin, which is a sign of disease. Something is wrong in your skin, which gives you a scale. Can you see the scale, please? And that's a visible falling of your skin, and that's typically a scale. Okay, now let's straight away go to slide 1. Let's straight away go to slide 1. Okay, for those who came and joined me late, I'm going to say this thing again, that don't copy this in the class. Don't copy this in the class. I'll be sending a PDF, or you can click this if you have a phone or something. You can click the screen. That's one option you have. Or I'm going to give you a PDF also of these number slides. Don't copy this inside your book. Leave a space in your book, and we will talk about it a bit later on. Okay, listen carefully. I'll give you time. So later on, you can leave a gap right now, and you can fill it up later. Is what I wanted to say. Now, this is an INICT question of the colors of skin and which disease they come. Silvery scales are seen with psoriasis. Silvery scales are seen with psoriasis. Fine briny scales, pityriasis versicolor. Collarette cell, pityriasis, fish-like ichthyosis, yellow greasy seborrheic dermatitis, and dandruff. Now, obviously, you have no idea what I've just said. This is all Greek and Latin, and maybe Bengali and Kannada and Tamil for North Indian people. Meaning, we don't understand what we just said, right? It's okay. There's a foreign language right now for you. Pityriasis rosea, pityriasis versicolor. Don't worry. At this time, you will not understand this. At this time, you may not understand this. Okay? But don't worry. As we go ahead today, you will find that many of these diseases will get covered. And that time, I will tell you what the fine Banani scale is, what the Collarette scale is. All this will come separately in separate topics. That time, you'll understand. At this time, it's okay. Just leave a gap. I just wanted to do this so that later on when you revise, all the scales are in one place. It's a very common question, and it always comes in a concept called as match the following. Match the following is a very common kind of a pattern of question asking, which is there in an INICT exam. So column A, column B, that's kind of a thing. So it's a good important understanding for that. Everybody okay? Are you understanding that we have to leave space, bache, in your book, and you can fill it up, bache, later on. Okay? Okay. Now that you understand this, okay? Now that you understand this, something very important, bache, coming up. Very important stuff coming up, okay? Write down, please. Whenever there is one term that we need to use, there's something called as acanthos. Acanthos means spine. Acanthos means spine. So we have two words, bache. Acanthosis and acantholysis. क्या words हैं? acanthosis and acantholysis. Okay, acanthosis, acantholysis. Acantholysis. Okay, acantho means spine. Okay, lysis means cut. Can you see a spine getting cut? Can you see this concept of spine getting cut? Spine means what? The desmosome. So desmosome getting cut. Clear, please? And this acantholysis is typically seen in pemphigus. This acantholysis is typically seen in the disease pemphigus. We'll talk about this later on. Okay. Acanthosis happens to be what is called as thick spinous layers. Thick spinous layers, and that is seen in lichen planus, eczema, and psoriasis. Lichen planus, eczema, and psoriasis are three disorders where you have a thickened spinous layer. ठीक है बच्चे? Thickened spinous layer. ठीक है? Clear? Everybody got this? ठीक है? Thickened spinous layer. Okay. Right. So there are two terms: acantholysis and acanthosis. Acantholysis is cutting of the spinous layer. Acanthosis is thickening of that. ठीक है? Okay. Now, what is the function of the desmosome? What does desmosome do? Let's understand, bache. What does the desmosome do? Why do you have a desmosome? Now, desmosome has also been called by one more name. Look at the name, please. Intercellular junction. What's the name? See, name itself tells you. Intercellular junction, right? Junction, it's joining. See now, I'll give you this very important concept and let's understand the desmosome. Now, in the epidermis to start with, in the embryo stage, you have circular cells. Now, you don't like circles in the epidermis. You don't want circles. You know why? Because if there are circles, there are going to be gaps. And through these gaps now, microbes can easily enter your body. So, environment is like a sea of microbes, HIV, leprosy. So, imagine they entering and you will get killed. So what if you are killed the moment you are born? Because you have circular cells, and environment always likes a circle because there is a gap and they come in, dust comes in, pollution comes in, water comes in, microbes comes in, and you are dead. So nature never wants a circle. This is a cross arrangement. This is not a good arrangement. So what does nature want to do? Nature wants to join them so that there is no gap. So what it does, interestingly, if this is a circle, it starts to pull out the circle from many sides. There are pulling out fibers. These pulling out fibers have been called as desmosomes. See what they would do. What desmosomes would do is, now see the step now. Now that you pull it out, if you see this now, will you not get a conical extension wherever you pull it out? Can you see this, please? So wherever you pull it out, you get a conical area, right? So now this becomes a polygonal cell. Can you see now? This seems to be a more superior arrangement than a circular cell. We don't like circles. We like more polygons. Yes, okay. Now what's the benefit of having polygons? Now see this benefit. Now if you see a polygon, can you see the polygons will touch better? Can you see what I just said? Polygons always touch better, and that's why it's an excellent thing. Are you with me on this, please? ठीक है? So desmosome का function क्या है? Desmosome, now I'll just say this here only, pulls out the cell. Yes, can you see that, please? Pulls out the cell. That's one function we know. ठीक है? One more function we know, it pulls it out. Okay. Now see this. Listen to this very carefully. There's one cell. There's one cell. Okay, two cells, right? Let's say this one cell. Desmosomes are sutures which pull out like this, right? So I'm going to draw that for you. So let's say this is the cell number A, and there is a pulling out force like this, pulling out. Okay. Interestingly, this suture will enter the other cell. Can you see what I've just drawn? The suture, the pulling out desmosome starts from cell A, pulls out, pulls out, pulls out, pulls out, pulls out, and enters cell number B. Can you see what I've just said, please? Okay. Why is it pulling? Why is it going there? Because it has to attach to another cell. It's almost like if you put a wire okay, between two walls to sukhao your clothes, to dry up your clothes. You have to have a hook on one wall and another hook on one wall so that you can just suspend the wire between that. Same way, one wall is cell A, one wall is cell number B, and that wire which is pulling the cell number A is entering inside the cell number B. Same way, there is one desmosome from cell number B which is actually entering the cell number A. So can you see this crisscrossing arrangement of the actual pulling out fiber entering the other cells, nearby cells? And then what happens is this almost becomes like a stitch, like a suture. Do you understand what I'm saying? Is it not like a suture? It's like, one into the second. How do you take a suture? If you take a suture, you go into one part of the skin, come out from the other, then go back in from there and come out from the first side, and then you tighten it up and the two skin surfaces join. That's exactly the same thing for a desmosome. Desmosome is between cells. As the desmosome tightens up, the two cells become closer, and as they become closer, there is no gap now between the cells. Tell me if you understood this, please. Everybody, give me a shout out whether you understood what I just said about a desmosome. Desmosome will pull out the cell, but also it's a suture joining cells together. Clear, everybody? Tell me. On board? I'm waiting for your answer on what I just said, whether you have understood that. Yes, Revti, thank you. Thank you, bache. Okay. Now, if this is going live on YouTube, I will not be able to see your questions on YouTube right now. Okay. I don't think I'll be able to see that. Okay. Uh, so if you want to ask your questions, you'll have to come on the Telegram. Okay. Right. Because I can't really see that here. Okay. Okay. Now, you understand why the desmosomes were called as intercellular junction. They're joining the cells together, bache. Just to show you what that actually looks like. Can you see this, please? Can you see what I just said? And this is your desmosome. D matlab, can you see this? They're polygonal cells now, you can understand, and they're joining the cells together. These are polygonal cells, right? And they are now joined by this yellow line, which is the desmosome in between, and that's what we know. Clearly understand this, please? Okay, okay. Now, can you again actually see the desmosome? Can you see the polygonal cells now? Can you see the polygonal cells? They're not circular cells, and they're being pulled. How beautiful to see. They are being pulled by that, and that is the desmosome that we have. In fact, if I cut the desmosome, that is what is called acantholysis. Clear? Everybody okay with this, please? And that happens in a disease which we'll discuss later, which is obviously pemphigus. Okay? Cool, cool. Very nice, very nice. Okay. Now, I'm going to give you an analogy. The first analogy for you to know about. We are going to give you an analogy now. The analogy is a printer paper analogy. Okay. The analogy, bache, is a printer paper analogy. Okay. And I love giving analogies. Now, what is the concept of printer paper analogy? Let me give you this perspective, please. Let me show you what I want to show you. The printer paper analogy. Look at this now. Now, if you buy printer papers from the market, okay, they're going to be a bunch of attached and stuck papers. Put it in a printer and give a printer command, all the papers go in together. Clear? Yes. Same way, your 4 epidermal layers of 4 printer papers. Stratum corneum, stratum gallosum, spinosum, basale, all are stuck to each other like printer papers. Right? So if you give a printer command, all the papers go in together, meaning all the epidermal layers move together under your finger. That's how it should be. Be like that, right? Now, what if now, see what I've just done. Can you see this, please? The stratum corneum has got separated. And there's a gap below the stratum corneum. So can I call this a subcorneal split? I can call this a subcorneal split. So 3 layers are together. The roof has kind of separated. So that gap always fills up with water. So we call this subcorneal blister. This disease, will write down later, listen first. This disease has been called as pemphigus foliaceus. This disease, bache, has been called as pemphigus foliaceus. Pemphigus foliaceus. Now if I push with my finger, now see this. Is this not pemphigus foliaceus, bache? You can see the split below the corneum. Okay, this is a split below the corneum. So I can label this as stratum corneum, and these are the three layers that you have below, and you have a bit of water in between, which can be called as fluid. How easy is this analogy now? Easy ho gaya? So now if I give a printer command, only the stratum corneum goes inside, not the below three layers. So now there's movement between the printer papers then. Same way here, if I push with my finger now, only the corneum moves, the bottom doesn't move. So there's a movement below the stratum corneum. So the corneum will separate in fact with this, and there's a raw area for us to see. Yes or no? If I do this for my skin, there's no raw area. But if I do this in a pemphigus foliaceus, you'll find, and strangely enough, you'll find suddenly a raw area creation. Can you see this please? What has just happened? The upper skin has just stripped off and a raw area has got created. So the top printer paper has separated. Yes? Okay? Clear? Okay. Look at the second situation where I am now saying the three layers are above and the bottom layer has got separated. So there's a gap above the basal layer. So can I not call this suprabasal split or a suprabasal fluid? So now I say this is the stratum basale only, and now the three layers are above, right? So this blister can be called as suprabasal blister. Now if I push with my finger now, can you see the three layers will move and the bottom doesn't move? Are you with me on this? Three layers will move, the bottom doesn't move. So again there's a movement between the printer papers only, but at a lower level. This sign where there's movement between the printer papers has been called as Nikolski sign, which is nothing but stripping of the epidermis, because there's a split in between the epidermal layers. Now I want you to now, I'll show you the video for what I wanted to show you. I have a video made for Nikolski sign and you will really appreciate that. अरे वाह, ऐसा होता है, अभी समझ में आएगा. Okay, I'm going to show you an animated video and real video of a patient that we actually did here. Okay, and that will help you understand the entire concept of Nikolski sign, please. Okay, now see this please. Now if you see this now, if you can understand now that there is, I'm trying to do something here. Can you see this? I'm trying to do something here, right? And this is basically a horizontal movement I'm trying to make with my finger. Now can you see this please? Can you see what just happened? Okay, there's a stripping of skin please, and that stripping of skin is the demonstration of Nikolski sign. Just check again please, just check again. Can you see this please? Horrendous, right? Very difficult to see. Can you see this actually? I'll tell you what happened once, and that really gives you a perspective of what sometimes, it can be very shocking sometimes. I remember it was my internship. I was in Mumbai. I'm in Delhi now. I did my MBBS a long time back. I don't know. You will be surprised to know. I joined my MBBS in '95. I finished my MD in the year 2005. Okay. And actually I started teaching in coaching institute in the year 2007. So now from 7 till 23, it's been about 17 years of dermatology teaching in entrance exam coaching institute. So it's been a long journey, but I still remember when I was in my internship, that was I think 2000 or something. I remember going to a derma, I was posted in dermatology as an intern, and one of my residents said, uska na, that patient please go and do blood collection, because that was the only thing interns were doing at that time. The only thing I did the full year was just blood collections, so I was to go with a syringe like this, like a warrior with a sword. So that was my sword, the syringe, right? And a mask and a stethoscope, like feeling like a doctor wanting to suck blood of patients like a vampire. And my because my patient never used to respect an intern, aa gaya खून चूसने के लिए. That was our identity. Anyway, so I went to a patient. So I said, okay, let me just take a spirit swab and just wipe this so that I can collect blood. So I did this a bit vigorously, unfortunately, and I did this, and the epidermis came off, and I'm like, oh. I said, I got so scared. I still remember running away from there. That I said, I thought I've done it, and my seniors will scold me. ये क्या कर दिया? तेरे को swab भी नहीं करना आता. Then later on, now I realized that was Nikolski sign, or maybe that was a pemphigus patient and that was Nikolski sign. And that is something that we have to know. That's exactly what happens in people of pemphigus. Yes, understood the pemphigus understanding, please? Okay. Again, can you see the same thing? Okay, this is basically that small epidermal thing, you can say this top layer has come off. It's a movement. Can you see this, please? Movement between the epidermal layers. Okay, bache? Okay. Please copy pemphigus foliaceus. Please copy pemphigus foliaceus. I'm intentionally going off the video, so don't worry, I'm here only. Okay, I just want you to copy the full slide so that I don't obstruct the slide also. Copy, please. Let me know when you are done. Okay, I think should be okay with this. Okay, pemphigus vulgaris. All right, suprabasal blister. Suprabasal blister. Done. Okay. So now that you understand this now tell me, if you can just tell me now, if you can just tell me now, if you can just tell me now, where would you have a thicker roof? Tell me, please. Where will you have a thicker roof? Vulgaris? Roof of what? Roof of the blister. Vulgaris or foliaceous? Tell me. Where would you have a thicker roof? Vulgaris, right? In fact, in foliaceous, there will be a thin roof and a thick floor, right? In vulgaris, it's a thick roof and a thin floor. Please copy. Foliaceous may copy, please. Thin roof, okay, and thick floor. Thin roof and thick floor. Thin roof and thick floor. Samjhe? And it's the opposite, obviously. It's the opposite, है ना? In pemphigus vulgaris. Vulgaris, PV will have a thick roof, right, and a thin floor. Everybody okay? You got that? Okay. Now I'll just show you what that blister looks like. Okay. Also write down one important thing. All epidermal blisters will be flaccid. Okay. All epidermal blisters will be flaccid. Flaccid means very loose. The word flaccid means very loose. Loose blisters. Okay. The word flaccid means loose. Okay. The word flaccid means loose. So I'll show you what a loose blister looks like. Can you see what a loose blister looks like? A flaccid loose blister will be, all epidermal blisters will that sense be flaccid. Okay, clear please? Okay. Now if I have any blister, let's say the 4 layers are there, okay, and the dermoepidermal junction, what if I say the fluid is here, right? We call this a subepidermal blister. Okay, subepidermal blister. Now the example of this disease is a disease we'll talk about later. We call this bullous pemphigoid. Okay, we call it bullous pemphigoid. Now this bullous pemphigoid is usually a tense blister. Okay, usually it's a tense blister. क्या कह रहे हैं? Usually it's a tense blister. It's not a flaccid blister. Remember this. It's a flaccid blister नहीं है. It's a tense blister. It's a tense blister. Okay, it's a tense blister. I'll show you what that looks like. So you'll understand very soon. I'm just going to show you that. 1 second. Okay, so let me show you what a tense blister looks like. So epidermal is flaccid and subepidermal. So can you make out the flaccid blister, please? है ना? Can make out the flaccid blister? Let me show you if I have here only. Let's just check. Huh. So can you see a tense blister of bullous pemphigoid? It's much thicker. It's much tenser, and that's actually because the roof is formed now by folates. The roof is basically formed by folates, right? And that's subepidermal blister of bullous pemphigoid. Okay, well, we'll talk about the pathology a bit later on. Everybody cool? Yes or no? Bataएं please. Okay till here? Okay. Now I told you that as you go up, you have about 1000 milligrams of keratin, right? Keratin gives you strength. So you hold a pen and with 1000 milligrams. Now what if some student is holding the pen more tightly than usual? I'm saying this again. What if a student is holding the pen more tightly than usual, right? Now the epidermis says, "Yaar, 1000 milligrams are made, but this fellow is putting so much trauma. My 1000 doesn't seem to be enough. So let me now make 10,000 milligrams of keratin on that one spot. So this area of stratum corneum will become thicker than usual. So this has been called as hyperkeratosis. See the name, hyperkeratosis means thicker stratum corneum. क्या बोलते हैं बच्चे? Thicker stratum corneum, because here the epidermis is forced to make more keratin against your own trauma from your own pen. So that area becomes thicker and harder. So if I just show you the image for what it actually looks like, and you'll be able to identify this. It's a very common thing. We see this a lot. Now can you see this please? Can you appreciate what I just said? Can you see this hardness and the thickness? And it's very common for students to get this after joining coaching classes, because in your MBBS maybe your classes were for like 45 minutes or so, and we are going to do 20 hours and 22 hours, and we are a short subject, right? Imagine that trauma for 20 hours. Okay, the epidermis doesn't know that you have joined DBMCI. Epidermis is going on कि यार ये तो MBBS में है, and he's in a class and he's going to bunk that class anyway. So let me only be okay with 1000. He doesn't know that DBMCI will force that keratin to become higher, and that's hyperkeratosis, and that's your own pen trying to give you this. Yes or no? Everybody got this? Yes or no? Bataएं please if this making sense for you, right? It's something that we see a lot. Okay, we see a lot of this now. We see a lot of this in people, right? Okay, now can you see? Now who can tell me what is this person doing? Okay, why is this area so thick? Tell me. Tell me. Tell me. Okay, now this is a person going to the gym. Okay, these are not my hands, but my hands are also like this because I go to the gym as well. So so what happens is when we lift a dumbbell, okay, yes, excellent Pranay, great diagnosis, spot diagnosis. Dekho, now obviously we see hands like this also. There's a little bit of the same thing here on my hands, even here, right? Very rough and very bad looking, right? What happens when you lift a dumbbell? You go on day one and you lift a dumbbell like that, 10 kilo dumbbell, right? You think, and wrongly obviously, that in 10 days your biceps will start to come, some definition will start to come of your biceps, right? आपको लगता है ऐसा होगा, but guess what? The trauma is not first on your biceps. The trauma is first on your stratum corneum, right? So stratum corneum become thicker and harder. So you'll be so surprised and you'll be so annoyed. Yaar, it's been a month. I can't see any biceps development, but I can see my finger development, my palm development, my skin has become thicker, right? So it'll be strange to feel that. Okay, so the skin becomes thicker faster than your bicep. बोले कि यही मोटा हो रहा है, मेरा बाइसेप्स तो मोटा हो नहीं रहा. अरे बाइसेप मोटा होने के लिए 1 साल लगेगा, and your skin will become thicker faster, right? Or somebody is using an axe, like a farmer using an axe and chopping wood like that, so it's pressure. Or I was in my class, one of the girls said, "Sir, I also have it." I said, "Ah, you go to the gym?" "No." I said, "I obviously know you are not a farmer. So why are you getting it?" She said, "I am a biker." Yeah. So then she likes to have those, big CC bikes. So she rides. So she's holding like this all the time for hours, and that zoom, 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 that is basically the hyperkeratosis. So that is what we need to know. One more thing for you to now see, please. Now, can you see this area seems to be more darker than the rest of the hand? Can you appreciate that, please? And why would that be? Because this is a concept in dermatology. I want you to write that thicker the skin, the darker it looks. Thicker the skin, the darker it looks. Okay? Thicker the skin, the darker it looks. Now, so that means there are two reasons. Okay? There are two reasons for dark skin. One is more melanin makes it dark, like that's the tanning thing, but even thicker skin makes it look dark. Okay? Copy please, copy this please. Thicker skin makes it look dark. Okay? Thicker skin makes it look dark. Okay? And we'll use this a lot. In the next 2 days, we're going to use this concept a lot. Now, can you see now whose hand is this? Can you? It's a student who's like sitting with multiple hours on the table, and this is that rubbing and the friction, and that rubbing and the friction is causing that thickness. So this is not more melanin, this is actually thick skin, and this thick skin is what is the darkness. I see many girls coming to my OPD, okay, saying so look at my elbows are so dark, they're looking so bad, I can't wear sleeveless, I know people say ah, such ganda elbows, and who will tell them? I think, I've done so many things, I've put my nimbu, I've scrubbed the lemon on it, I've tried to exfoliate it, I'll try to scrub it, but nothing comes off. What happened? I said, all right, that's because of pressure. That's not more melanin, that's hyperkeratosis, right? Again, can you appreciate that? People who sit cross-legged on the floor, the pressure point will start becoming harder and obviously blacker. Yes. Now, if you see people in the Muslim religion, as they do namaz, they'll just kind of pray, and with that center point which is touching the floor, have you ever seen that? That's actually going to become black and dark, and that's typically the disease we are talking about. And it's not a disease, sorry, it's just your compensation of your skin. It's your composition of skin, and obviously that gives you that particular thickness and the hardness. Yes or no, please? Right? Okay, so I hope you understood this very common phenomena with so many of us actually would have. Now you have an explanation of why it actually happens, right? Okay, so now cool. Now listen to this. Okay, now let's also, we understood the Nikolski sign. I think we forgot to write down the Nikolski sign. I think we forgot that. So let me just put it here. Okay. So I'm sorry, I think we have missed it there. So we have to complete that. वो वहीं पे हमें pemphigus में लिखना चाहिए था, but we can write it here also, no problem, right? Okay. Now, the Nikolski sign, okay, is write down seen in diseases with epidermal splits, epidermal separation. Okay, epidermal separation. Example, pemphigus, where what happens is on lateral finger pressure there is raw skin formation. Okay, you understand this, please? Okay, raw skin formation is a wound which happens. Now Nikolski is only defined for movement between epidermal layers. Okay, now in bullous pemphigoid the separation is below the epidermis, so if I push with my finger there's no movement between epidermal layers, there's movement below the epidermis. So we will say Nikolski sign is negative in subepidermal blisters because it is defined for movement between epidermis. Yes or no, please? Everybody okay with this? Yes, Maheshwari, student's elbow. Yes, I understood what I'm saying. Student's elbow. Let's call it student's elbow. Okay? Or a teacher's elbow also. Because teachers also sit like that. So I sit like that on the desk, right? Okay, cool. All right. Now let's go to bache epidermal cells. Are you with me in this understanding? I hope it's not difficult. I hope all of you have been able to get a hang of this till now. I'm deliberately trying to go slow, and I'm trying to ensure that you don't find any difficulty in assessing it or seeing it also. Right. Now in epidermal cells, the first one is, let's use a short form KC. KC stands for keratinocyte. KC stands for keratinocytes. Now it seems the keratinocytes are there in all four epidermal layers. All four epidermal layers have keratinocytes. All four epidermal layers have keratinocytes. Okay. Okay. So stratum corneum has keratinocytes, stratum granulosum has keratinocytes, but the amount of keratin is different now. 1, 10, 100,000, but all of them seem to have keratin, and that's the cell now, keratinocyte, and obviously they have keratin inside, and this keratin is for strength. We know keratin is for strength. We would know. Clear? Okay. In fact, in the epidermis, we can also tell you that the basal layer seems to have a special keratin called as keratin 5 and keratin 14, and the upper layers, okay, have a different keratin, and that's keratin 1 and keratin 10. So corneum, granulosum and spinosum seems to have a different keratin, okay, seems to have a different keratin. Stratum granulosum, stratum spinosum and stratum corneum seems to have a different keratin, which is keratin 1 and 10, and now basal layer has a different keratin, which is keratin 5 and keratin 14. We'll use this concept later on. The basal keratin is different. See, the number is 1, 10, 100,000. That's the absolute number of keratin. This is the quality of keratin I'm talking about. There's a different type of keratin in the basal layer and different type of keratin in the upper epidermis, right? That's what the keratinocyte concept would be, seems to be in all the layers. And around the keratinocytes, we now understand that these are those spines that we seem to have, and we understand that the D means desmosome. Okay? So keratinocytes are now surrounded by this spinous projection, which is desmosome. Okay. The second one, the second cell, let's talk about, is a melanocyte, which short form is MC. Okay, MC. Now melanocyte is only, it seems, in the basal layer. It's not in the entire epidermis. So I'm going to make now a basal epidermis में ही cell. Okay. Now this cell का function is not to make keratin but to make melanin. Okay. Now why do you need to make melanin? Melanin is for ultraviolet light protection. Melanin is for ultraviolet light protection. Now why do you need protection against ultraviolet light? Let's understand that. Now to understand this, I'm going to show you a video to make you understand why it is so vital to have melanin in your epidermis. Okay, so vital to have epidermis mein melanin. Okay, let's understand this, please. Let's understand this whole concept of why melanin has to be so vital for us. Okay, okay, listen very carefully. Let me show you a video, please. Again, this will give you a wonderful understanding on what really happens. Okay, not this, sorry, I've played a wrong video. Sorry, not this one. I'll give you a different one. Yeah, this one. Okay, let me just draw something for you here. Okay, now just to show for all of you, this is what I've drawn black is the dermoepidermal junction, right? Dermoepidermal junction, right? And this is your basal keratinocyte. See what I've drawn? What is all basal keratinocyte? Okay, I'm using a different color now. This here is your melanocyte. Let's assume that it does not have melanin. So the cross means there is no melanin inside this melanocyte. Let's assume that. Now when it is not there, okay, so let's rub this off so there is no confusion. Okay, so this melanocyte, sorry, has no melanin. So I'm going to write that up, no melanin, okay, inside this. Now ultraviolet light hits. Now, ultraviolet light unfortunately damages your DNA, right? So let's assume this cell has this double-sided DNA inside. So it's now going to hit it. Now, if there was melanin inside, let's assume, then the ultraviolet light would be absorbed and it cannot hit your DNAs. But because I'm saying it's not there, now the DNA is going to be damaged. So when this DNA is damaging, there's DNA mutations. Okay? And there's a daily damage because daily you get sunlight. This DNA damage is very risky, and this I'm going to show you in the video now. Just play, I'm going to play this video, please. Right? Okay, listen to this carefully. Okay, let's go step by step here. So now see, right now, just focus on this, please. Right now, I'm saying the DNA seems to be okay inside this melanocyte. DNA seems to be okay inside the melanocyte. Okay, now the ultraviolet light hits. Okay, just observe now. Can you see now what I've just drawn? This pink just signifies a DNA mutation. Pink just signifies a DNA mutation, right? And this mutated cell now, see, DNA is very important to control cell division, right? It's primarily responsible for cell division, right? So when there is some problem in the DNA, the mutation has happened. Now the DNA doesn't control that division. It's a very unregulated division of this melanocyte. So just appreciate that, please, now. So this melanocyte has become damaged. Can you see this proliferation now? Right? Can you see this over mass of proliferating cells? And this then is called a melanoma. क्या बोलते हैं बच्चे? Melanoma. Melanoma is basically a malignant melanocyte. Melanoma is a malignant melanocyte. Now, can you see what's happened? The vessels, interestingly, have started going into this mass. And why would that be? Because obviously the cell is dividing so fast that the cell needs nutrition and food, and that's why the body is actually giving it that nutrition and food. In fact, that's why if you thrombose these vessels, okay, by stopping the nutrition, and which is then in many cancers, you kind of embolize those tumor cells so that they don't get that nutrition. But this is just the body's way to support it, because body knows melanocyte is a self tissue, meaning melanocyte is your own thing. No, melanocyte is not COVID, so body doesn't want to kill it. In fact, body wants to support it. And that's why one of the biggest problems in cancer is the body is growing, the cell is growing, but the body supports it. Body doesn't kill it, though ideally it should kill it. From a cell here, which is LC, called as Langerhans cell. We'll talk about Langerhans cell very soon. Langerhans cell is a Bullous cell. Langerhans cell is supposed to pick up COVID, for example, and take it and then get it killed. But why? Can you see it's not picking up your melanoma cell? Why is it not picking up? Because it's not recognizing it as a foreign body. It's recognizing it as a normal cell. And that's why one classical therapy that we do in many cancers is what is called as immunotherapy. Immunotherapy means the immune cell, the Langerhans cell, for example, which was sleeping till now, not able to identify this melanoma cell, starts to wake up and say, oh, sorry. Even though it's my own tissue, I also need to pick up my own tissues because this tissue is damaging me, and that is what we will now understand. Can you see a beautiful video now? Can you see the role of melanin? And this would all not happen if you have a bit of melanin inside, and that's the entire concept of tumor pathogenesis. And we make melanin for ultraviolet protection, because write this down, since chronic UV light is carcino. Can you see this, please? Actually, I could have just showed you this sentence in one line, but why did I give you a video? Because this gives you the clearer understanding on why we need that beautiful amount of melanin in the skin. In fact, more the melanin means less cancer, no? Less skin cancer, no? So the darker you are, the better it is, and the fairer you are, the worse it is. And that's what the best skin you can hope to have. Best skin you can hope to have is a jet black skin. So if you sleep in the night, you should, wish for God. God, please, in the morning, make me jet black. God, I'll be so thankful to you if you really give me that black skin in the morning. But यहाँ पे people are struggling with black skin in India. Psychologically, they want fair skin and fair skin and fair skin. And that's why so many fairness creams are there in the market. Because we have this in India, we have this whole unfortunate tendency to want to become fair. So I always say, oh, you want to have fairness? That means you're wishing for skin cancer. So applying that fairness cream is akin to wanting skin damage. And in fact, African skin doesn't have cancer at all. And who's struggling with cancer? Australians, Americans, Europeans, Scandinavian countries, because they are fair people. And on top of that, they are going and doing sunbathing and biking and playing volleyball on a beach. And on top of that, Australia has a ozone hole to bless them even further. Can you see the trouble for them? No wonder that if they have less melanin, they are dependent on what? Sunscreens, right? And that's why sunscreen use is more important for an American and Australia, even though Indians need it. But can you see the requirement for them is obviously that much more than what we have for us, because we are already dark. We have some degree of melanin already inside. Think of melanin as a natural sunscreen. It's a sunscreen all of us are born with. God possibly knew that, in India we don't want to spend a lot of money. We have that miser gene, that extra chromosome we had called as miserly gene and saving money philosophy, right? And God understood कि ये तो खर्चा करेगा नहीं, and sunscreen is expensive, so let me give him the sunscreen by default, and the darker you are, the more sunscreen I have. Clear, please? Okay, cool, very good. So did you understand the whole concept, please? Everyone correspond with me, talk to me whether this is understood now to you. Okay, now we know, interesting, that keratinocytes don't have melanin now. The keratinocytes don't have any melanin, है ना? So then, interestingly, now listen very carefully. Interestingly, okay, clear? Okay. Now, melanocyte has melanin. So I'll give you an example. Analogy I give you is, I can give you an analogy of Warren Buffett. Okay, I can give you an analogy of Ratan Tata. Okay, let's look at that now, analogy wise. I don't know if you know who Warren Buffett is. Now, Warren Buffett is one of those celebrities of the world, and rightly so. I admire him a lot. He's a very rich man. I don't even exactly know his wealth, but I think it's, to put an arbitrary number on it, I think it's about $134 billion. I don't even know what that number means. And interestingly, 99% of that wealth, I think, has gone to charity. What a man. Earning that much money, and 99% has gone to poor people, and only he keeps 1%. I mean, that's a different fellow. He could be God also. So same thing with these big philanthropy people of India, who have made sure that even though they earn money, they also send it out. So think of melanocyte as Warren Buffett. Lot of money means lot of melanin. And think of keratinocyte as a poor fellow who has no money. Melanocyte, don't worry, yaar, I'll give it to you, right? So now the melanocyte starts making finger-like projections, and from these fingers, it now sends money to the poor people, and now that is how the keratinocytes also get protected in the epidermis with this donation. In fact, one melanocyte will give melanin to 36 keratinocytes. Okay, one melanocyte gives melanin to the 36 keratinocytes, and we call this epidermal melanin unit. क्या बोलते हैं? Epidermal melanin unit, which seems to be 1:36. Okay, बच्चे, which seems to be 1:36. Everybody with me now? बताओ समझ आ रहा है कि नहीं आ रहा? Can you see the power of analogies? It's helping you understand some nice, beautiful concepts of skin, and we can link it to people like Ratan Tata and all this kind of a thing. So let me just give you the video again, please. Again, it helps you understand things here much better. Okay, now can you see now? See this now. Can you see this now? The dendritic process, the finger-like projections called as dendritic processes. Can you see the melanins now traveling inside? Can you see the melanin traveling inside now? Okay, now this is the skin now. You can see this now, right? You can see now dendritic process here, right? And you will see now the transfer. Can you see the transfer, please? From the melanocyte, this through the dendritic processes, and now see this now. You'll see the transfer. Can you see the transfer, please? Rich to poor transmission, right? Cool, please. And that's what we know, right? That's what we know, right? You can see now that it's actually got transferred. right? So if I were to show you this now, one melanocyte here, can you say it's transferring it to so many people, right? So that one rich person is sending it to so many poor people. That's the epidermal melanin concept, the transfer happening from the rich person to the poor person, right? Happening from the rich person to the poor person. Cool. Easy. Are you able to understand, bache? All right. Very nice. Very nice. Now, how do you make melanin? There's an amino acid tyrosine, and then you make melanin. You know? With action of enzyme tyrosinase. Interestingly, tyrosinase is absent in a disease which is albinism. No wonder that people who are albinos will have zero melanin. Like how an American also struggles because he has less melanin. Albinism has zero melanin. So you can understand the amount of carcinogenesis in albinism. Hannah, please? Okay. Alright. The third cell, bache, to know is Langerhans cell. LC. Now, Langerhans cell is called an APC, which basically stands for antigen presenting cell. Okay, APC, antigen presenting cell. Okay, now antigen presenting cell is a cell. How do you say this now? Now, look at the analogy. Again, I love this analogy. India, Pakistan, and line of control. Look at the analogy, please. India, Pakistan, LOC. Let's look at this analogy first. I'll show you a wonderful video for this, and this will give you a great perspective on what we are trying to say. Look at this, please. Okay. Now, so this is your line of control, and this is the Pakistani space, and these dots signify terrorists which want to come into your place. So obviously, because there's a fence, they have to go back every day, right? Now let's assume there's a gap in your fence someday, and the terrorists now are coming into the Indian side of the space. Now we have this BSF person now, border security force, who picks up this fellow and takes him to the HQ, means headquarters. So now the terrorists are in the headquarters. Headquarter will analyze who this person was. It's like, bhai, kaun hai tu? Kahan se aaya hai? Show me your Aadhaar card. Show me your PAN card. Do you know where are you staying? All that stuff. You know, they come to know he's not from India. So obviously the headquarter will say, oh, this is not the right person for you to have. So let me now kill this fellow. Hai. So this is how the police will work. Let's look at this analogy now. Think of these terrorists now, okay, as microbes. Think of Pakistan as the environment, okay. Think of line of control as the stratum corneum. Usually there's no gap in the stratum corneum, so the microbes have to go back. But what if now there's a gap, meaning there's an injury? How can injury happen in the skin? Either you are playing cricket and you fall down and you get a wound, or you are scratching with your own nails, right? Who's the BSF person? The Langerhans cell. So Langerhans cell now picks up your microbes. Okay. Now when they pick it up, they will now send it to what is the headquarter now? Tell me, every adult should now. Headquarter is a lymph node. Headquarter is a lymph node. So lymph node now gets the antigen. So now that's why Langerhans cells are called as antigen presenting. They're presenting the antigen to the local lymph nodes for processing. Lymph nodes now, interestingly, lymph nodes now have two immune forces inside. Now let's call it T cell and B cell. Right? Now if you have usually viruses, so T cells get activated and they will go back. If you have bacteria, okay, obviously there are exceptions, but in bacteria you will have B cells and antibodies, and they will go and kill the bacteria. And that's how the immune system functions beautifully in your skin, and that is the entire concept of this. Now, understand this please. Everybody got this clearly? Okay. Now, this T cell and B cell can also be called in one more way. Th1 and Th2. Th1 means you make T cells. Th2 means you make B cells. So T helper 1, T helper 2. And this is how the immune system beautifully functions. Let me show you a video for that. Again, that helps you understand the Langerhans cell behavior so beautifully. Okay. Listen to this now. Okay, so let's show you the video here, bache, on what we are trying to show you. Okay, so let's say now that this is your scratching of a patient who's got a disease by the name of eczema. Eczema patients, can you see, are scratching a lot because they have a lot of itching. So if they have a lot of itching, what will happen? Listen carefully. Okay, can you see now the itch? Yeah. Okay, now this is, now you can see now in this area, can you appreciate that there is absolutely zero gap? And all these epidermal cells are joined, we would know, by the desmosomes in between, which is the suture connections, we know that. And that's why they're very tight. Can you see these are polygonal as well? Can you appreciate that, please? So if whatever microbes come in, will come in and go back. So nobody actually enters. But let's assume you're talking about a patient who's got eczema, as I said, where they scratch a lot. So just to appreciate that for you. Now can you see what just happened? Can you see now there's a gap? Because they have just kind of damaged their own skin. Now can you appreciate this Langerhans cell here? Okay, can you appreciate the Langerhans cell here? Okay, I'll just have to remove my own video from here, because otherwise I might be occluding the slide. Just a minute, please. Okay. Okay, so you can hear me now, but you can't see me now. Okay, now, so this is your Langerhans cell here. Okay, this is your Langerhans cell here, right? So now see what happens next. Now this is a condition where, because the skin is open, you can now appreciate that things will come inside. Just check now. Can you see the foreign substance now? And then just focus on this cell now. Okay, look at the Langerhans cell now engulfing that particular microbe. Yes, and now it will start moving out. Can you see it start moving out now to the lymph node? And can you see the concept of TH1, TH2, please? Okay, now this is, now it's giving it to TH2. Matlab it would have possibly picked up a bacteria like staph or something, right? And this is T helper, so it's going to be B cells and antibody creation and a lot of immune system, and that will then hit the particular antigen which actually comes inside, and that is what we know as the entire beautiful thing of Langerhans cells. Now, one more thing for you to appreciate now. Let's go back. Okay. Now, what if I'm saying that it is not picking up the foreign substance? What am I saying? That it's not picking up the foreign substance. In fact, there is no foreign substance coming inside. What if this is a melanocyte, as we know, right? Melanocyte. What if the Langerhans cells by mistake pick up your own melanocytes? Meaning here the if I go back here, what is the Langerhans cell picking up? The Langerhans cell is not picking up a bacteria. In fact, the Langerhans cell is picking up his normal Kashmiri brother. Is that not what I'm saying? They are picking up the normal Kashmiri brother, not picking up people from outside. Okay, so getting back to the video, if I now tell you, just concentrate very classically on this. Very important stuff coming up. Okay, very important stuff coming up. Please pay attention. Okay, now see. So we are talking about normal situation. Right? Let me just push this video ahead so I can. Okay, remember this now. Okay, so I'm saying now, Langerhans cell now picks up your own melanocytes, and Langerhans cells send it to the lymph nodes. Lymph nodes make T cells, and the T cells come and unfortunately blast your own melanocyte. So that melanocyte, when it's gone, okay, the overlying skin here starts becoming white. This white skin disease will be called as vitiligo. Okay, this white skin disease has been called as vitiligo, and this vitiligo is obviously an autoimmune disease, right? And you have to always know, we'll write it down later also, autoimmune is always acquired. So nobody is born with autoimmune disease. Okay, nobody is born with autoimmune disease. They only get autoimmunity much later in life. So see, like how albinism, by the way, albinism, I'll come back now. My video can come back now. Okay, see, so now I understand. We say that vitiligo is an autoimmune disease, where the Langerhans cells don't pick up microbes like how they should, but they pick up your own cells. And when they pick up your own cells, they are damaging own cells. And that's a Kashmiri brother being picked up by the BSF. And the Kashmiri brother is taken to the lymph nodes, and the lymph nodes say, "Maar desko." And that's an autoimmune disease. Everybody understood? Okay, please. No confusion, please. No confusion, please, on this. Okay. What if the same Langerhans cells? What if the same Langerhans cells pick up the desmosomes? Desmosome picked up by the Langerhans cells, right? Langerhans cells go to the lymph nodes, and now the lymph nodes kill the desmosomes. That is acantholysis, and that is pemphigus. So pemphigus is an autoimmune killing of desmosome. Vitiligo is an autoimmune killing of melanocyte. Cool, please, everybody. Tell me if this was understood. Should be easy. Should be easy. Please copy. Please copy. So video does help us now in understanding the pathogenesis of this disease. And can you see the benefit of looking at analogies? Benefit of looking at analogies. Okay. Okay. Copy, please. Now, if the Langerhans cell picks up melanocytes picked, then it is called vitiligo. If desmosome picked, we'll call it pemphigus. Are you understanding? Give me an update, please. I'm trying to make it very simple for you so that there's no confusion and you don't have any complication understanding. There's often difficult disorders, but I'm trying to give you an analogy. The LOC Pakistan analogy does help us, I feel, in remembering it a lot better. Are you finding it simple, bache? Okay, let's talk about the fourth cell, which is Merkel cell. लिखिए Merkel cell are touch receptors in the basal layer. Merkel cells बचे are touch receptors in the basal layer. Touch receptors in the basal epidermis. Touch receptor in the basal epidermis. Done? Let me know if you're done, bache. All right, good. Okay. Now listen to this analogy now. Listen to this very important slide number 2. Slide number 2. Please pay attention to slide number 2. 1 minute. Let me just push this on the side so I think I don't obstruct it. Okay. Listen to this now. Now I'm going to give you another analogy. I remember when I was a small child. I used to be fascinated with astronomy, the universe, the rockets, and when they used to say a million light years, I used to say, million light years, what is that distance? Because light year means one, no, that's a big distance, right? And a million light years, like how? So it was fascinating. So I've developed a lot of kind of interest in astronomy, in space, in the army, and the missiles, and the rockets, and so like. So I'll give you one analogy according to my interest, and that's a rocket analogy. Now all of us know about Elon Musk, right? I think now he's become the third or the fourth richest, not the most richest now. So that keeps on happening. But one of his biggest companies, which is like a blockbuster company now, is the SpaceX company, which launches rockets into space, right? So imagine what a guy that would be, right? He's thinking about how to launch humans into space and humans into Mars. And some of us are wondering whether our maid servant will come in the morning for work or no. Oh, maid servant nahi aayi. Oh, life is screwed. Yeah, the maid servant. So, and he's thinking about how to send people into space and Mars. So So I'll just give you this analogy now. So this is the analogy of a rocket launching up from SpaceX centers, right? So see what happens is when rocket goes up, after some time the rocket kind of becomes a bit slanted, right? Then a bit more and a bit more, right? So can you see the rocket becomes more and more horizontal as it goes up? Yes or no, please? Okay. One more thing. The maximum energy usage is right at liftoff because it has to escape gravity. There's lesser energy usage here, even lesser here, even lesser here, right? Because it's got momentum. So as you go up, you have lesser and lesser fuel requirements and it becomes more and more horizontal as it goes up, right? So see this now. Same way, your basal cell is that Elon Musk rocket, which is obviously vertical at liftoff, but needs a lot of energy. So that's why it has a lot of ATP production with a bit of nucleus. So I've drawn a very big nucleus inside this basal cell. Hai na? Now the spinous cell is a bit slanted, but can you see it's got less energy requirements? So obviously it has got lesser nucleus, right? Now this is even lesser and this is even lesser. So as you see, can you see the keratinocytes also becoming more and more flatter as it goes up? And then obviously nucleus also shrinking as it goes up, and this is typically why we always say it is behaving like a rocket going up, where the cells become more and more horizontal and they lose nucleus at every step. We already know it's about 28-day time. Okay, that's called transit turnover time, though some books will be a bit controversial about it. Some will say 52 days, some will say 76 days. So there's a bit of an argument on the number, but let's just for a non-controversial sake, let's call it 28 days, so about a month, and then we know the cells would flat launch off, and that's the falling off that we know. So can I not say it takes 28 days for a nucleated cell to become non-nucleated on an average? It takes 28 days for a nucleated cell to become non-nucleated on an average situation. Are you with me on this, please? Everybody got this? Yes or no, bache? Okay. Now, what happens in the disease psoriasis? Please copy. With this you have to copy. Now, psoriasis happens to be an autoimmune disease. Okay. Psoriasis happens to be an autoimmune disease where the cells now have a big nucleus, but they divide more rapidly than usual. Okay. And why would that be? Because it seems that a lot of T cells now, these are T cells which are stimulating this basal cell to divide. Okay, which are stimulating the basal cell to divide faster than normal. So they are going up not in 28 days, it seems to go up in just about 4 days. So we know that it's a very rapid onset going up. It's a very rapid onset going up, right? And when that happens, what will actually happen is it's too fast, right? It's too fast. Now, if it's too fast, the cell does not have enough time to lose nucleus. So will you then not have a nucleated stratum corneum bache in psoriasis? This nucleated stratum corneum then has been called as parakeratosis. Parakeratosis is a histopathology term for a nucleated stratum corneum in psoriasis. Okay, and that happens because obviously the cell is going up so rapidly, you don't have time to shut off your nucleus actually, and that's what we would know. Right now, also the cell goes up, but it seems the falling is also problematic. After going up, the cell finds it difficult to fall off. So then the cells keep on accumulating in the top with a bit of traffic jam there, and that's actually hyperkeratosis, thick cornea. So two things are happening in psoriasis. The cells are nucleated and the cells don't fall off on time, and that's the hyperkeratosis situation. That's a classical scenario of psoriasis. Let me just show you. Can you appreciate now the thick hyperkeratosis? The thick skin hyperkeratosis, because it's not falling off at all, right? And if you biopsy this will be having a lot of nuclei inside. Okay, just to show you. Now can you see the normal epidermis now? Okay, from here to here is normal, right? Now you can appreciate that the bottom layer seems to be all nucleated, but can you see the upper layer doesn't seem to be nucleated? It's a non-nucleated corneum, right? That's so it takes that time. Okay, that's a normal epidermis, right? Clear, please? Okay, now can you appreciate the parakeratosis now? Can you appreciate the parakeratosis? ठीक है, the nucleated stratum corneum typically in psoriasis, and this is the basal layer, and it goes up more rapidly than usual, so it doesn't really have that time. So this is just an example of a bit of nuclei in the corneum. Now that means if I want to treat this situation, one treatment would be to remove the T cells, and that is done by some symbolic drugs, which is methotrexate. We can give cyclosporin. Okay, we have a therapy which we'll discuss a bit later on called as phototherapy. Okay, we also have, okay, let's not talk too much here, maybe we'll talk about it when the psoriasis topic actually comes, but this is more of all a treatment for the T cell inhibition. One more option would be, why not remove the keratin with a keratolytic drug regimen. Keratolytic drug. Okay, the keratolytic drug that we tend to have, okay, is this one salicylic acid, we know. Okay, and a group of drugs, again we'll discuss that in detail later on, which are called as retinoids. Now retinoids have a way to cut it. We can cut that word, retin and oid. Oid means like, retin means vitamin A. So can you say the name means vitamin A like drug, everyone? Vitamin A like drug. Cool on this, please. Tell me if you understood this, and if there's any problem in understanding, please let me know. Okay, ठीक है. All right, now let's talk about a very important aspect. Okay, let's talk about some very important aspect. Now let's go back to pemphigus. Let's go back to pemphigus to tell you exactly what happens in pemphigus. Now going back to pemphigus, now I told you in pemphigus the desmosomes get cut, right? We saw that earlier as an autoimmune phenomenon, है ना? And this process was बच्चे called acantholysis. Welcome Hodgkins, love your name. Okay, I love the creativity of your name sometimes. Okay, and many of them, one of my, I'll tell you one of the names that I would have kept for myself, if I wanted to keep a pseudonym. There is one name I always have liked. Okay. And there is a type of psoriasis which we'll talk about tomorrow, and the name is so nice and humorous in that phonetic way. Von Zumbush. You look at the wordplay on that, Von Zumbush, right? So it's, I'm giving you a new option for your new name, right? So Hodgkin's Von Zumbush, right? So you'll also remember the name of the disease. Oh, the more cancers around. Okay, there's a lymphoma lurking around, right? Somewhere Hodgkin's lurking around, right? Okay, so you can have this new name that I want to share with you. Okay, now let's talk about pemphigus now. Now you remember I told you that the remember I said that the work of a desmosome is to pull out the cell. The work of the desmosome is to pull out the cell, right? So what happens in pemphigus? Slide 3, please. See, very important stuff coming up. Very important stuff coming up. Please pay attention. Please pay attention, right? Okay. Now, if the desmosomes get cut, focus on the yellow circles. Okay, slide 3, don't copy. If the desmosomes get cut, okay, now I'm put a cut on this now. We'll put a cut on this, right? The small cut. I told you the desmosomes pull it out. So if they can't pull it out, will it not become like an embryonal thing, right? It was circular to start with, right? And it becomes that circle again. And this circular cell has been called as acantholytic cell, also called as Zank cell. क्या बोलते हैं? Acantholytic cell or Zank cell. Okay. Now that Zank cell allows fluid to be there inside, and that fluid, okay, is an epidermal blister. That fluid is an epidermal blister, and that is basically a fluid in between the circles. That fluid is in between the circles, and that is typically the epidermal blistering, and that's why we get it. Can you see the circular cell, please, of pemphigus? We call them acantholytic cell, and we have already seen, see, can you see this multiple acantholytic cell, okay, in this particular, can you see this, please? In fact, this is the blister that we are. In fact, what we do is we can actually break this blister. We can actually break the blister. Okay, we can break the blister, take the fluid, okay, and do something called a Giemsa stain. Okay, in this Giemsa stain, okay, if they have the Giemsa stain, then you look for these acantholytic cells. Yes, please. So that is what we do. These acantholytic cells are these circular cells which are uninucleate, meaning single nucleus. Uninucleate giant cells will be seen in pemphigus. We'll talk about later tomorrow about something called as multinucleate giant cells. That's a different thing. Multinucleate giant cell is different, okay, and uninucleate giant cell is different. In pemphigus, we get uninucleate by the fluid, and this is basically the uninucleate concept. Okay, you can see this single nucleus and single cell, you know, and this is floating in the blister cavity. Now we have to understand why in desmosome the pemphigus got cut. Let's understand that, please. This is your keratinocyte, and this is the desmosome in between, है ना? Desmosome in between. Now desmosome has a protein inside for strength. ठीक है? This yellow is a protein and we call it desmoglein, short from DSG. Okay. Now this DSG protein is for strength. This DSG protein is for strength. Okay. This is a normal protein. What if this DSG? What if the DSG is picked by the Langerhans cells by mistake? Now, Langerhans cells are dendritic cells as well. Like how the melanocytes are dendritic cells, even Langerhans cells are dendritic, and they will now send it to the lymph nodes. Lymph nodes give a Th2 response, meaning B cells, meaning antibody to the DSG. Okay, just listen very carefully. Antibody to the DSG. So can I not call this an anti-DSG antibody? Typically of the IgG type. Now this will go and hit your DSGs. Okay, so when the DSG is gone, can you see this, please? DSG has been destroyed as an autoimmune phenomena. What happens next as a consequence of that? See this, please. This is the keratinocyte. Can you see now the desmosomes become hollow from inside? Become hollow from inside. Now if they're hollow, they're going to be weak as well, right? There's no strength inside, and that is when the desmosome will break. And the moment the desmosome break, the cells now shrink into a small circle and the fluid comes in between, and that is the pathology of pemphigus. Everybody tell me if this was understood, bache. Everybody tell me if this was understood, everyone, or is there any confusion on this, please? Okay, should be okay. All right, cool. Right, now slide 4, very important. Slide 4, please. Pay attention, pay attention. Let me just drag it to the left side so it's easier for you to see. Okay, now that you understand pemphigus, it'll be easier to understand other diseases also. Okay, come on, tell me, bache. You have to continue to tell me how you felt about whatever topic we are doing. Okay, everyone, no confusion, please. Okay, slide 4. Let's go step by step. Just focus on the yellow circles. I'm going to make some yellow circles. Now A and B are the two epidermal keratinocytes. C is the basal keratinocytes. Now the red line in between are the desmosomes. The red lines are the desmosome joining the cells together. Okay, we know the desmosomes are going to be completely smashed in people who have pemphigus, and we know pemphigus and anti-DSG antibody that we have actually understood. Okay, so that I'm not going to revise. Now this basal cell has to be also connected below to the dermoepidermal junction. So this blue line, as you can see, this blue line is one more suture that we have, that's called hemidesmosome. So desmosome, the desmosome connects two keratinocytes together. The hemidesmosome connects the basal cell down below to the dermoepidermal junction. A hemidesmosome also tends to have a protein called as BP1. Like how the desmosome has desmoglein, hemidesmosome has BP1. Now in people who have bullous pemphigoid, they start having an anti-BP1 antibody of the IgG type and the BP1 is smashed. So the hemidesmosome goes. So when the hemidesmosome goes, will you not have fluid below the epidermis? Right? Because now the hemidesmosome got cut. So that is bullous pemphigoid, and that we already know that we had said it's a subepidermal blister because it's actually a hemidesmosome damage. In pemphigus, it's a desmosomal damage. In bullous pemphigoid, it's a hemidesmosomal damage. So obviously in bullous pemphigoid, we do not use the term acantholysis because acantholysis is a term only for desmosome. Acantho means desmosome, right? And that's why we can now differentiate. Copy this, please. Copy this difference between pemphigus and bullous pemphigoid. Pemphigus and bullous pemphigoid. Please copy, I'll wait. Let me just remove myself also from here so you can have unobstructed view of this. Okay, so pemphigus, what is broken? Desmosome. Bullous pemphigoid, hemidesmosome. Acantholysis, yes pemphigus, no bullous pemphigoid. Blister, epidermal, subepidermal. Nikolski, yes in pemphigus, no in bullous pemphigoid. Cool? Yes. Okay. Now, when we talk about blisters in dermatology, what is the term blister? Now, whenever we talk about blisters in dermatology, if the blister is less than less than 0.5 centimeter, we call it a vesicle. An example of vesicle, we'll talk about that this disease later on, is herpes. And when the blister is more than 0.5, the name that we give it is bulla. Bulla. Bulla, as we know now, can also either be flaccid or tense bulla. Okay. Bulla flaccid would be pemphigus, for example. Tense bulla would be bullous pemphigoid, for example. Understand the term blisters, please. Blister is an English word. Blister is not a dermatology word. So blister can either be small or big. Small means vesicle, big means bulla. So if I just show you this now, can you see this vesicular rash, a vesicular lesion, small fluid lesion, something like herpes or varicella or chickenpox, for example, right? And this will be a flaccid bulla and this will be a tense bulla. Understood the sequence, please, everyone? Cool? Okay, right. So let's push this ahead now. Let's go more into pemphigus. Okay? Okay. Good, good. Okay. Now, we know the entire epidermis has desmosomes. No confusion on that. The entire epidermis has desmosomes, right? Entire epidermis has desmosomes. But desmogleins are different. Upper epidermis has desmoglein 1, lower epidermis has desmoglein 3. Upper epidermis has desmoglein 1, lower epidermis has desmoglein 3. Okay. Now, desmoglein 1 seems to be maximum between corneum and granulosum. I'm saying this again. Desmoglein 1 is maximum between corneum and granulosum. Desmoglein 3 is maximum between spinous and basal layer for all of us. Okay. Now, as an autoimmune phenomena, if you have pemphigus foliaceus, you will only make anti-DHE1 antibody. The DHE1 is collapsing. You will have acantholytic cells only between corneum and granulosum. Okay, fluid comes only there. That's at the subcorneal level of fluid collection. If you think desmoglein 3 is bad, anti-desmoglein 3 antibodies. So acantholytic cells between spinous basal, fluid comes there, and that's why it's a suprabasal level of fluid collection. So that the reason when we have suprabasal and subcorneal is because of this now. It's basically because of which antibody forms and where you have acantholysis and which level you have that fluid formation. Everybody, yes, focused? Okay. Leave space for slide 5, please. Okay. Now, if I showed you pemphigus foliaceus now, see this, please. Okay. So, stratum corneum, then a bit of water. and granulosum, spinosum and basal are together. So can you see in pemphigus foliaceus, the basal is still stuck to the spinous layer. See, let's say my left hand is the basal cell, right hand is the spinous cell, and they are stuck like this. Listen very carefully. So basal cell is stuck to the spinous layer. The basal cell is stuck to the spinous cell. Now basal cell is usually vertical. Basal cell is usually vertical, this one. Now the vertical cells cannot be seen very well because it's stuck to the spinous layer. So you can't see margin in between the basal and the spinous because it's stuck. So you cannot make out the vertical cells very well in pemphigus foliaceus. But see vulgaris. In vulgaris, the basal has got separated from spinous layer. Why? Because in pemphigus vulgaris, we'll actually say this, right? Okay. So basal got separated. So if the basal is got separated, you will start seeing the margins properly of the basal cells. And we know basal cells are vertical. So that we know that vertical cells will be very well seen only in vulgaris because they're separated. All these vertical basal cells have been compared to tombstones in a grave. So क्या बोलते हैं? Row of tombstone appearance in pemphigus vulgaris because the cells are looking like tombstones. But in foliaceous, why don't they see? Why they're not seen? Because they're stuck to the other layers. Just to show you that. Now can you see this now? Stratum corneum lifted up. A bit of water below that and all the three layers are, so can you see the thin roof and the thick floor, and this would be pemphigus foliaceus. Okay, versus now look at this now. Again, it's a very important. Now tell me the diagnosis, bache. Let me wait for you. See if you can just pick it up. I'll wait for you to answer this question. Everyone attempt it. कि क्या दिख रहा है बताएं मेरे को please. Tell me what do you see. I'll wait for your answer. Which pemphigus is this? Everyone, which pemphigus is this? Okay, tell me, how do you diagnose this? Okay, now how do you judge this? First, always see. Okay, see, yeah, the split has started to happen from here. Just see whether the roof is thick or the floor is thick. Can you make out the floor seems to be thicker than the roof? Right? Plus, if you can appreciate, there is no nucleus. Right? Can you appreciate that there is no nucleus, okay, in this area? Can you make that out, please? There is no nucleus in the top. Right? So this seems to be a corneum. So the floor seems to be thicker than the roof. Sorry, floor seems to be thicker than the roof, and that happens only when you have what? Remember the disease, and that's pemphigus foliaceus. Right? So it's a subcorneal split because it seems that the roof is thin and the floor would be thick. Look at this, please. Now 1 minute. I think this got hung a bit. Give me 1 moment. I'll just see if I can zoom out. Okay, can I just close this, please? Give me 1 second. I'll just close it and reopen it. Okay, so this was pemphigus foliaceus. Then look at this. Can you see thick roof and thin floor? And that is pemphigus vulgaris. You can see the gap. If I show you the gap in a bit, this basal cell in a bit more detail, can you see the row of tombstones, please? The row of tombstones, please. Right? A lot of vertical cells in the basal layer looking like tombstones in a grave. Okay. Now the next analogy I want to give you, again, look at this. We are having a sea of analogies, right? I give you the India-Pakistan analogy. I give you the suture analogy for a desmosome. So multiple analogies we want to create. One more analogy on this, I think, is a great analogy, is the analogy of a brick wall, and a brick wall. Now we know bricks, and we also know there's a bit of cement in between the bricks, and this cement binds the bricks together, right? So we are not happy with only having, we are not happy with only having the bricks. We also need to have a bit of cement in between to bring it together. So think of these bricks as keratinocytes, and think of this as a cement which is almost like Fevicol joining it together. So it's not enough to have only bricks, we need to have cement. And we can now also understand these black lines are the desmosomes in between. So now there are two ways to stick the keratinocytes together in the epidermis. One is a desmosome mechanism, one is a cement mechanism. At the moment, we only know about the problems with the desmosome with pemphigus. We don't at the moment know the problem with the cement. But we'll talk about now a disease now where the cement is gone. Interesting, the desmosomes remain okay. And that is a disease called as eczema. So in eczema, what you will understand, the cement is lost. See, if I just show you this, can you see this area of a gap? Can you see this, please? This gap is because the cement is not there. So I put a bit of water here to fill up that gap. Any gap fills up with water, but this is a fluid in between normal bricks. In pemphigus, the fluid is in between circular bricks and circular acantholytic cells because the desmosome got ruptured. Here in eczema, you still have fluid in between cells, but that's in between polygonal cells and polygonal keratinocytes. Are you with me, please? Everybody got what I just created? So let me just draw this for you, please. Please copy this. Let me know when you're done. Okay, everyone, हो गया? बताओ हो गया तो? Come on, talk to me. Okay, now slide 6. Not only people who have eczema or dermatitis have the problem of the cement not being there, okay, but the desmosome are there, and cement is not there. So that space is going to be filled up with water, and that's a space in between polygonal cells. This space in between polygonal cells has been called as intercellular edema or spongiosis. So I'm saying this again. It's a fluid in between the circles, in between, fluid in between the polygons, and that fluid in between the polygons, okay, fluid in between the polygons, fluid in between the polygons is intercellular edema or spongiosis. Intercellular edema or spongiosis. ठीक है? Listen carefully. Listen very carefully. Okay. So can you appreciate this, please? Okay. Can you see this gap in between the polygonal cells? And this, you can even see the desmosomes are actually intact. Can you appreciate that, please? Desmosomes are actually intact. And this intact desmosomes allow this cell to be polygonal, and that empty space fills up with water, and that is spongiosis. Okay. Now, interestingly, the amount of water, so can you see the amount of gap here is not too much versus see the amount of gap in pemphigus, quite a lot. So in pemphigus, the gap is so much that you actually have a blister, but here the gap is not so much, so I don't get a blister. I actually don't get a blister. What you get is only on biopsy you get a fluid. Clinically you don't have water. Okay. Histopathologically you have water. Clear? Now we know pemphigus, eczema patients scratch a lot. Why? Because itis means inflammation. Though they do this. So when they do this, can you see this cracks now? Can you appreciate, please? The cracks are nothing but your nail marks. Now because of that, what will happen is now the fluid which is up till now suppressed inside your epidermis starts to come out of that cut. So all eczema patients usually will say that when I scratch in acute eczema, there's water coming out as oozing. So eczema patients don't have too many blisters to show us, they have more oozing. Please write down, please. Acute eczema, write down as oozing or exudation. Oozing. or exudation. Okay, please copy. Oozing or exudation. Are you with me on this, please, everybody? Okay, so leave space, bache, for slide 6. Okay, all right. Now let's go to slide 7. Everybody with me? Tell me if you are on board and you're able to keep pace with me. Are you able to understand? Maybe for the first time, you're able to understand pemphigus, acantholysis, acantholytic cell, eczema, all that. I hope no confusion, bache. I'll wait for your update and feedback. See, online class, I'll be very honest, is slightly tougher for us to take as faculty. Slightly tough for you to also concentrate because you're alone, right? In your own house, you're not in a group. The dynamics of group teaching is definitely different. But here also we can give you equal amount of efficiency, and but for that I need you to be able to correspond with me every few minutes. Okay, right? Normal. I'm talking about normal skin now. Okay. Now just let's go to this now. Now this red line, this red line is a keratin filament. Okay, this red line is a keratin filament. Now these keratin filaments, when they are separate, when these keratin filaments are separate, they don't give us a lot of strength, right? Separate things don't give you strength. You have to join them for strength. I told you keratin gives you strength. So we tend to have something called as filaggrin, which is this blue thing. Can you see this filaggrin, please? Okay, this filaggrin is this blue dotted structure. This filaggrin actually is something which joins together. Give me a moment, please, on this. Filaggrin, 1 minute. Okay, fine. Now, filaggrin is a structure. Okay, filaggrin, we like filaggrin a lot because filaggrin seems to join the keratins together, and this joining gives us the strength that we require. This joining gives us the strength that we require, right? Filaggrin gives us strength that we require. So filaggrin is a very important thing. Now filaggrin needs calcium for its function. Filaggrin needs calcium for its function. Without calcium, I don't have filaggrin function, right? Okay. Now we know that desmosomes pull out the cell. We understood that. Calcium is very important for the desmosomes also. So calcium is a very central part of your skin because it helps your filagrins and also helps your desmosomes. Okay. Now there is a pump called as calcium ATPase pump, and that pump pumps in calcium all the time, 24 hours in a day. So there's a lot of calcium inside your epidermis, inside your cells, so that the filagrin works and also the desmosomes do their job normally. Okay, that's what it is, right? Now there are two diseases. One is called Darier's disease. One is called Hailey-Hailey disease. Darier's disease, Hailey-Hailey disease. And in both Darius and Hailey-Hailey, what will happen? See, there's a problem. Don't copy, please. There's a problem in the pump. The pump is not there only. Okay, there's a problem in the pump. So when there's a problem in the pump, the calcium doesn't seem to come in at all. So I'm going to rub off the calcium now, right? And when there's no calcium, now the filaggrin I will rub off. So these dotted lines are not there. So can you see the filaggrin is not working? So keratin filaments are separate, and that's why this is a weak keratinocyte, interestingly, since birth. Okay, and I also remove the desmosomes because the desmosomes don't seem to work also. So now the pulling is not there. So this now cell becomes a circular cell, empty space in between. So can I not call this acantholysis? But interestingly, since birth, so it's going to be a fluid since birth, and that is acantholysis. Acantholysis, got that, please? Acantholysis. Understand? Everybody got this clearly? Okay. Now this acantholysis will give me a blister at birth. So what is this disease we are talking about? Darius and Hailey-Hailey have everything congenital, okay, everything circular, a bit of space in between, and a weak cell. Please copy now. I'll wait for you to copy this. I'll wait for you to copy this, please. And if you're not understood, I want you to let me know. I want you to let me know. Okay? Okay, good. So now, so when you understand this, now let's talk about Darius in a bit of detail. Let's talk about Darius in a bit of detail. This you will have to write down. So let's go step by step on Darius. In Darius, we know that the first step is obviously a circular cell and a weak cell, right? So circular cell, weak cell since birth, right? Now, epidermis understood that something has to be done, right, about this weakness. So it doesn't do anything about the circle, it remains a circle. But what it can do, it can increase the number of keratin filaments. Can you see this, please? So we now say it still is circular, but now there is compensatory increase of keratin inside the cell, है ना? So now the strength, it seems, comes back. The strength is now back. It's not as weak a cell as what it was. It's somehow a better cell. But the problem is the keratin synthesis doesn't stop only. So now I say there is overcompensation. Overcompensation means there's too much keratin, right? And this too much keratin means very thick hyperkeratosis. So interestingly, even though we now in the beginning thought that in the second step when the keratin increased, we said, oh nice, there's compensation, achhi baat hai. But in the third step, there's too much. So that becomes an extra problem for the patient. And because it's a circle, we obviously know it's a blister also. है ना? समझे? So obviously now we understand this blister is a congenital process, a genetic process. It's not an acquired disease like pemphigus, है ना? Listen, एक और बात समझिएगा. Now, when I showed you a pemphigus blister, there was a blister, right? There was a fluid that you could see, something like this, right? For a fluid to be there, for a fluid to be seen, it has to push up the skin. So overlying skin has to be soft. But in Dariers, there is this kind of hyperkeratosis, very thick skin. It's such a bad thick skin that no matter how much water you have, that water cannot push up this hard skin. It's almost a stony hard skin. And that's why in Dariers, we know that this blister is not seen clinically. Because it's such a hard skin, what you see is hyperkeratosis. So hyperkeratosis is seen clinically. Are you with me on this, please? Hyperkeratosis is seen clinically. You don't really see anything else. You don't really see the actual blister. Okay, you don't really see the blister because for blisters to be seen, as I said, it has to push up, and I don't really see a push up because it's such a hard skin. Everybody understood this, please? No confusion on Dariers, please. It's blister, not blister is seen on biopsy. Clinically, I don't really see it. ठीक है बच्चे? ठीक है? All right. So let's look at now the histopathology of Dariers. देखिएगा. Now normally what did I said? What did I say earlier? 1 milligram of keratin, 10, 100 and 1000. ठीक है? Now in Dariers, basal layer 1 milligram of keratin. Now in Dariers, the skin is so anxious to make that compensatory keratin that the spinous layer itself has 1000 milligrams. Normally the 1000 should have been in the corneum. Can you see it's early because the skin wants to make that compensation? This we call this premature keratinization. समझे? This premature keratinization has a name. We call this क्या बोलते हैं बच्चे? डिसकेरेटोसिस, क्या बोलते हैं? डिसकेरेटोसिस, डिसकेरेटोसिस। ठीक है, एवरीवन ऑन बोर्ड? डिसकेरेटोसिस। All right. Radon in Hailey-Hailey disease now. We have done Darier's. Radon in Hailey-Hailey, there is no compensatory hyperkeratosis. In Hailey-Hailey, there is no compensatory hyperkeratosis. ठीक है? Hence it presents as blisters only. There is no compensatory hyperkeratosis. ठीक है? Hence it presents as blisters itself. Everyone understood, please? Hence it presents as blister itself. I'm going to show you because there's no compensation. So the presentation is not going to be a keratin presentation. There's no compensation. So presentation is a blister presentation only. So image I'm going to show you a bit later on, where there is a soft skin on top and the fluid can push it up. ठीक है बच्चे? Okay. बच्चे एक चीज I want to tell all of you that notes are not being sent, okay, in the PDF. Okay, you have to write all this down. Okay, if all of you are thinking that the annotated notes are going to be sent, no, please. Okay, you have to write those notes. Okay, what will be sent are all those numbered slides only. Those numbered slides will be sent, that I'm going to spend, but don't think that whatever I'm writing on the notepad that is going to be sent, put no. Make an effort to write it when I'm talking about it. Okay, all right. Now why is there no compensatory hyperkeratosis? Because it's a different genetic mutation. Even though both are calcium pump problems, okay, there are different genes involved in Dariers and Hailey-Hailey. Okay, there are different genes involved in Dariers and Hailey-Hailey. Okay, in Dariers, the gene which is going to be involved allows the compensatory hyperkeratosis to happen. Okay, whereas in Hailey-Hailey, okay, that gene which is involved doesn't allow the compensation to happen. You understand this, please? Okay. 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 Now let's talk about one more disease. Write down, please. It's called EB. Okay. Now EB is called epidermolysis. B is bullosa. Okay. EB. Now that these are also called as trauma-induced blisters. क्या बोलते हैं बच्चे? Trauma-induced blisters. Trauma-induced blisters. Okay. Now see what it is. Now we have EBS, EBJ, EBD. Okay. EBS, EBJ, EBD. Now EBS means epidermolysis bullosa simplex. J stands for junctional. D stands for dystrophica. See the name, please. EBS, EBJ, EBD. Now they seem to be a congenital group of disorders. Listen to what happens. Now to understand what is EB, okay, to understand what is EB, let's see now. Okay, let's see what is EB now. Now let's say I'll give you an understanding and an explanation now. So let's say you are in a punching game, like a boxing game, and somebody punches you here, cut, big thing. Now this trauma, it's trauma, right? Now this trauma has to be absorbed by someone. So you have a lot of keratin in the epidermis to absorb that trauma. So we are saved. The epidermis is saved from that boxing punch. Junction also has to be strong to save itself from the punch. So junction, dermoepidermal junction has a structure called as laminin, which gives that structure a bit of strength. Dermis has something called as collagen, which gives it strength. So epidermis has keratin for strength, junction has laminin for strength, dermis has collagen for strength. Now what happens in EBS? There is no basal keratin since birth. What do you mean by basal keratin? Remember what I had said, keratin 5 and keratin 14. It's absent. Upper epidermis is okay, junction is okay, dermis is okay. ठीक है? Only the basal keratin is not okay. Only the basal keratin is not okay. Okay, so what happens now? Simple. Listen to this guy. Now, if you do a boxing punch now, the basal cell is weak because basal cell does not have keratin. Samjhe? Basal cell doesn't have keratin. So see what will happen. Slide 8. Listen to this very carefully. Don't copy. Now, if you have trauma in EBS, now the basal keratin is absent. So now the keratinocyte in the basal layer is weak. So that trauma breaks the basal keratinocyte only, no? And when the keratinocyte has broken, there is an empty space that fills up with water. So it's a blister in the basal layer. It's not above the basal layer, it's inside the basal layer. Okay, meaning in EBS, this is the dermoepidermal junction, right? The basal cell itself has broken. So the bricks itself has broken in the basal layer. Bricks itself have broken in the basal layer. See this important, very, very important thing to consider. In eczema, the problem was this cement. The cement was not proper. In pemphigus, the problem was these desmosomes were not proper in pemphigus. In EBS, the problem is the brick itself. The brick itself is not proper because the bricks are weak since birth, so it's a broken brick. So trauma-induced blister in the basal layer. Got that, please? Okay. Now in EBJ, you have absent laminin in the DEJ since birth. Okay. So continuing with the same slide 8, one more slide 8. On trauma now, because the junction doesn't have laminin, the laminin is broken. So the empty space there, the blister comes there. So now the blistering is in the junction area after trauma. Same in EBD, you don't have collagen in the dermis since birth. So the trauma now breaks your dermis. So now 3 types of epidermalized bullosa: EBS, EBJ, EBD. In EBS, you don't have basal keratins. In EBJ, you don't have laminin. In EBD, you don't have collagen since birth, right? EBS, EBJ, and EBD disorder, right? Now, out of all the blisters that we have seen, can you see only pemphigus and bullous pemphigoid had antibodies? Rest did not have antibodies. So fortunately now we have a test in dermatology called as DIF. DIF. DIF is a test for antibodies. So now is it not easy to understand that pemphigus and bullous pemphigoid are called as DIF positive disorders and rest are DIF negative. Please copy this. Please copy. Please copy. DIF. We'll talk about DIF in detail very soon. It's an important topic. But this is just an introduction of this. Okay, everybody clear? Okay. Now just as a summary, see if you can pick this in a brick, cement and desmosome analogy. If the brick is okay, cement is okay, desmosome is not okay. We'll now call this pemphigus. Okay. Brick is not okay, cement is okay, desmosome is okay. EBS. Brick is okay, cement is bad and the desmosome is okay. This would be eczema. So can you see this beautiful analogy that I brought up? Just with the cement analogy and the brick analogy, we can understand such complex disorders of pemphigus and EBS and eczema. You can see where the actual disorder and the pathology lies. Everybody on board, please. कोई दिक्कत नहीं है, I hope. Right. So this then finishes the first session that we wanted to do. Okay. We did it in a lot of detail. I hope you enjoyed this. What we did, we created a base for you. In the next session, which we're going to do one of my favorite disorders, acne. And I'll speak about so much about the acne myths, and we'll also for the first time open the entire world of nutrition to you in this next session. and it's going to be a very joyous time for you to understand ki, okay, how do you look at rice? Okay, now what happens when the rice goes inside and what happens to it biologically? So I'm not speaking about those complex biochemistry enzyme equation kind of discussion. No, we are not talking about those very difficult Krebs cycle enzyme kind of discussion. We are going to be a very practical thing. What happens when a honey goes inside, when what happens when rice goes inside, what happens to insulin resistance and sugar and glut receptors. Very practical way, and you will understand for the first time कि, oh, we didn't know this is what was happening when we have a morsel of masala dosa in the morning. So that's going to be the second session. We're going to do acne, adnexal disorders, melanins, so a lot of things coming your way in the second session. So I hope you enjoyed and participated with me, and you could understand something about it. Dermatology is something which is usually alien. I hope you have had some grip already, but we're going to do a lot of it. We'll expand a lot of it in the second session. Thank you so much.